We are live.
Welcome, everyone. Good evening, and welcome to Gyan Pravah, the Flow of Knowledge podcast series, episode number 96. And myself, Dr. Sita Ramamurthy Pal, chairperson of the Genetics and Fetal Medicine Committee, Fogsi, will be your host for today. This podcast, this innovative concept, is the brainchild of our visionary and dynamic president, Fogsi, Dr. Sunita Tandulwadkar, where on the 4th of every month, sharp at 8 p.m., I will be coming with a guest talking on different aspects of fetal medicine. Today, we are going to explore the frontiers of fetal medicine from around the world and dive into a fascinating conversation comparing different aspects of different healthcare landscapes. And joining us today is our guest speaker, our own Dr. Mandeep Singh, a leading fetal medicine and fetal surgery specialist with deep experience in this field. And our topic for today is global perspectives on fetal medicine, comparing practices and challenges. Together, we are going to explore how clinical practices, patient experiences, ethical challenges, and technical innovations vary and what each country can benefit from each other. But before we start our conversation, I would like to introduce, and thank profusely our president, Dr. Sunita Tandulwadkar, who has brought out this concept. And as she said, that we have evolved ourselves with every podcast. We are getting to learn more. We're getting more experience with it. And, this is a beautiful platform for us to reinvent ourselves. So thank you for that. Besides being a very busy president, where even 24 hours is not enough for her, she's also been the past president of IAGE, the president-elect of ISAR, and also the president of Society of Ovarian Rejuvenation. But besides all this, besides her clinical work, she has managed to touch every Foxian and every woman at large across the country with multitude of her projects, which have come up in such a big way in the last 4 months. One of us is the Gyan Pravah. One is the Arogya Yoga Yatra, where spirituality combines with medicine. And again, we are we are reinventing ourselves there. The Do Tike Zindagi, which is our fight against cervical cancer. The Eagle Project, which has touched so many PG students where they're getting to learn laparoscopy in their own institutes under the hands of expert, and many more such evolving projects. So thank you, Dr. Sunita, for all your ideas, innovative concepts, where everything is from idea to conception implementation is perfect, and we are enjoying the fruits of it. So thank you once again. I would like to welcome you to give your words of wisdom. Thank you.
Thank you, Sita. You are so kind. You are so generous in really naming all our flagship program. They are so close to everyone's heart. And these programs are really rocking only because you all are working so absolutely non-stop. Every committee chairperson, Mandeep, is working very, very hard. Apart from their committee, they are doing all my programs, and I'm thankful to them. And actually, when I see them, the way they are taking their podcast, their dialogue, their interaction, I see the future leaders in them. They can lead the Foxy given a capacity. So I'm very proud of them, and I wish them all the best. And Sita, this is your third podcast. You are all fourth one. All heard from Dr. I think South Indian, Dr. Suresh was your first.
Yes.
I can't forget, they were absolutely great. And today you have chosen Mandeep. I'm sure this will be academically so enriched, beautiful, and useful to each and every Foxian. Thank you, Mandeep. Thank you for coming on a Foxy platform. And thank you for being with us. Thank you.
Thank you. Pleasure's mine.
Thank you. So it is my proud privilege to introduce Dr. Mandeep Singh. As I said, he's one of us. He's from India, and we're so proud of him that he's a global figure now. He's a highly experienced British-Indian subspecialist in maternal fetal medicine and fetal surgery, having done his education in India, and now he is the director of the Kypros Nicolaides Fetal Medicine and Therapy Center, Abu Dhabi. He attained his FRCOG in 2023 and obtained certificate in fetal surgery from International Center for Fetal Surgery and Therapy, Bogota in 2022. He is trained in fetal medicine with the legend of fetal medicine, Professor Kypros Nicolaides, and he's also obviously had the diploma in fetal medicine in 2021. With a proven track record as a leader in healthcare, Dr. Mandeep Singh brings extensive expertise in clinical practice and healthcare management. And his focus on the intricate aspects of fetal medicine and surgery has allowed him to make significant contributions to the field, ensuring the well-being of both the unborn fetus and the mother. And he has led the team in Abu Dhabi that has performed the first in utero spina bifida surgery. So congratulations, Dr. Mandeep, for that. And he has performed more than, I think, about around 8 to 10 in utero surgeries, spina bifida surgeries after that. He has established international centers for fetal surgery in UAE and also has managed to create a vast academic and clinical network in neighboring countries like Ethiopia, Europe, and obviously India, where we are benefiting a lot from his expertise. Beyond his clinical expertise, he has excelled in healthcare management as well, where he showcases his leadership abilities by successfully leading the merger of 3 hospitals into a large trust in the United Kingdom. He has played a pivotal role in creating a unified and efficient healthcare system that enhances patient outcomes, experiences, efficiencies, and patient safety, of course. Needless to say, he has numerous original papers and publications to his credit, and he has been the principal investigator in many research projects, especially one of the most important ASPRE study of aspirin in preeclampsia prevention. In summary, I think, Dr. Mandeep, we are very proud to have you here today. And you're a specialist distinguished in maternal and fetal medicine and surgery, a proven leader in healthcare management, and a visionary professional dedicated to the care of mother and the fetus. Thank you for joining us today. Thank you.
Thank you, Sita. Thank you.
Thank you. Thank you, Mandeep. Our protocol says now both of you will have a dialogue, and I'll be joining the viewers link to be with you all. Thank you.
Thank you.
See you on other end.
Thank you. Thank you.
Thank you.
So, Dr. Mandeep, I can call you Mandeep, I think, is that's if that's okay with you.
Good.
But
Absolutely.
it's always been a pleasure to talk to you. You're so soft-spoken. And but I would like to start off with your journey. You know, you've done your education in India, and then you traveled to the UK. Now you're in Abu Dhabi, leading a big center for fetal surgery. Just take us through your journey and, how it has been for you and how you've come up to this stage.
Thank you, Sita and Dr. Sunita. For a lot of people who don't know, Dr. Bhaskar Pal was my senior and guru that a lot of us that went to the UK followed, because he showed us the way of how to help others, how to guide others, and how to ensure that people who come to the UK, whether you know them or you don't know them, because I didn't know Bhaskar at all, to guide them to success. And I think we all are very grateful to the path that Bhaskar, and of course supported by yourself, have shown many
Thank you.
national medical graduates now. Thank
But a
you.
lot goes to your credit as well. So take us through your journey.
My father was on a transferable job, so we used to get transferred every 2 years. And finally, when I was in my 12th standard, reached Maharashtra. And then we decided that we will not move anymore. And then I got admission in a medical college in Maharashtra. For those who know, it's Dr. VM Medical College in Solapur. So I did my MBBS from there. And obs and gynae, I was okay, but that wasn't my preferred subject. But at that time, we used to get post-graduation in the subject that you scored the highest. And I, for some reason, scored the highest in obs and gynae. So there was no double thought about it. And everybody said that I should do obs and gynae. So I did obs and gynae. And I've passed my MD from Meeraj. That's where I did my post-graduation from. And only in the final year of my post-graduation, I realized, what have I done? Why did I come into obs and gynae? But it was probably a passing thought. I really enjoyed obs and gynae, and after doing my post graduation, I wanted to further my experience. So took up a lecturer post in a medical college in rural Maharashtra in Dhulia. It's sort of a tribal area, not anymore, but at that time it was. So me and my wife packed our bags and went to Dhulia, stayed there for 1 year, and that's where I really learned my obstetrics because I was the only lecturer supported by two very good professors and a hospital which just had enough to be able
Basic.
to do
Yeah.
basic stuff, and there were a lot of complicated obstetric cases coming along all
Yeah.
the time. So that 1 year changed my life. And even till today, I tell everybody that the obstetrics that I learned was in Dhulia, and that is with me for the rest of my life.
Absolutely.
Complications like severe preeclampsia, rupture uterus, severe anemia, pulmonary embolisms,
You
you
are
name
still
it,
and
and
have it, yeah.
it was there. That's then I thought, okay, now I need to earn money. So I thought, okay, let me go to Mumbai and start my private practice. And I was very happy until that time. And then when I decided to come back to Mumbai, I think that was a pivotal decision, but it had to be made because I was always sure that I wanted to go and do private practice in Mumbai. Came to Mumbai, worked in various parts of Mumbai, went through a very, very difficult time. And that's when I thought that this is a very difficult thing. And I'm telling this because there are many young
Yeah.
graduates just come out of medical college and are going through the same journey as I did 25, 30 years ago. And things weren't easy at that time as well. I think people think that things are bad now. They were bad at that time as well.
Good.
Uh, People said different things. Oh, you are a man. How can you do obs and gynae? You are a man with a turban. Women will not come to you. You are a Punjabi, a Sardar. People won't come to you. Different sort of things. But um, came from a middle class family, so didn't have money to build a big hospital. And that's the story for many of
Of
us.
them, yeah, most of them.
Yeah. And but then there were a lot of good people that I met in that time. I met Uday Thanawala, I met Hima Divakar, I met Dr. Suresh. I met many people who basically said that I should not lose heart. Dr. Hima Divakar actually asked me to do MRCOG and sort of further my career. So I met a lot of good people who also guided me to take the next step. And that's when at that time there was a lot of demand for doctors in the UK, and I did my PLAB, and fortunately I got through in my first attempt. And then I thought, okay, let me go and do MRCOG, and then I'll probably come back to India, as we all think that we will come back. Um, I then went to the UK, and I was very clear that I have had a very difficult time in India. I'm just going to go down, settle down, and have a good life there. And when I went to the UK, the easiest thing to do at that time was general practice. So I
Yeah.
thought, okay, I've done my obs and gynae. Why struggle in obs and gynae anymore? Just do GP and settle down there. And that's when I met one of the consultants from Cameroon. He just came and he said to me that you're good in obs and gynae. Why do you want to leave obs and gynae? So I said, see, I have no intentions of struggling anymore. Just get me into GP. And he said, see, if you listen to me and come with me, I'll introduce you to Professor Kipros Nicolaides. He's a guy whom, if you work for 3 years, he will change your life. And I thought, come on, why do this again? Um, but he insisted that I come with him. So we went one evening, he took me to London. And on the way, I did not know what fetal medicine was because I'd just come out of my MD. At that time, for me, fetal medicine was giving amino acid infusions to mothers with growth
Yeah,
restriction.
nothing much then.
Yeah, we used to send our women to operation theater to have oxygen because that was one of the theories that if growth restricted mothers have oxygen, then the babies grow well. And that was fetal medicine for me. And so meeting Prof. Kipros was a big change. and I didn't know much about fetal medicine. And before I entered into Prof. Kipros's room, and those who have worked with him know that it is very difficult to meet him. If he gives an appointment for 6 o'clock, you'll be lucky to see him before 12 o'clock in the night. So I was waiting for him outside his office, and then I get called in after 1 hour of my other consultant going in. And I was told that when he says, "What do you want to do?" you have to say, "I want to do research." Don't say you have to do you want to do fetal medicine. So I went in and I said, "Oh, I want to do research." So he said, "Okay, fine, come join tomorrow. We have a study going on, which is the progesterone study." This was 2007. He said, "I want you to start recruiting for the study." So I said, "Yeah, fine." And that's how I met Prof.
Very
Kipros
good.
and joined the group.
Yeah.
Yeah. Eventually, I finished my research. I then went into training. I did we have to do our CCT again in obs and gynae in the UK. So I got the training number in East of England. I did my training in the East of England, which is Cambridge, that area. Then I was again lucky. I was in Calcutta. I wasn't very sure whether I wanted to do subspecialization or not. And I was with one of my other colleagues, a senior colleague whom I regard a lot, who Sita and Bhaskar know, Yatin. I asked if I should do subspecialization, and he convinced me that evening in Calcutta. We had a conference in Hayat. I don't know if Sita remembers or not,
Yeah,
in
yeah, of
2000.
course you do. Yeah.
He convinced me that I should do subspecialization. And one of our other colleagues, who was a supervisor of subspecialization, Manjiri Khare, happened to be there in that conference. So I met her and she said I should apply for subspecialization. And I got the subspecialization. 3 years I did subspecialization in maternal fetal medicine in Leicester under Manjiri. And then by the time I finished my subspecialization, Prof. Kipros called me again and said, "I've got a consultant post for you. Come back to London. What are you doing in Midlands?"
Wow.
So I went back to King's. I became a consultant there. Then I set up a fetal medicine unit on Kipros Nicolaides' name in Essex in 2014. I ran that unit till 2022. Then I came to the UAE, obviously to earn some money, because you don't get much money in the UK anymore. Uh, so here I set up another unit, and I got an opportunity to learn fetal surgery and perform a few procedures. We've done around 11 spina bifidas in the last 1 year. And it's also very close to India. So that's sort of been my background and my journey in from medical school to where I am today, Sita.
Amazing. You've got, I mean, I must say you've been so lucky to have been actually given to Cyprus. Here you are, you have a student and learning from him. And I think you've had the best of everything in every country. So that's been really amazing. But from there, like having worked in different parts, like of India, the rural, the urban, and in the UK, and now in the UAE, how do you see the differences in practice and especially when you compare the similarities or differences, whatever we have in India and then in the UK and now in the UAE? Do you find a lot of similarity or a lot of differences? How does it, and how has that changed your practice actually? Let me put it that way.
Yeah, so I think one thing remains at the core is that medicine hasn't changed. Medicine is not a 9 to 5 profession, and it's not a profession that you can, or a branch where you can come in and go out. It's a way, as Prof. Kipros always says, that medicine is a way of life. It's not a profession. So we need to forget about, you need to be 100% involved into your care. And we were always told that when the patient looks into your eyes, they should feel that you feel the same as they are. And I
True.
think that has not changed whether you are in India,
Yeah, every
whether
woman
you
is the same wherever you go. Yeah,
absolutely.
yeah.
Absolutely. And obviously, there are clinical, cultural, and social differences in each country. In the UK, it's under the NHS, which is a fully funded public healthcare system.
Mm.
Everybody gets care free of cost at point of care, closer to home as much as possible. And obviously, the things are changing there as well. Culturally, UK is supported by the royal colleges. So we have guidelines for everything. We have strong networks. We have strong tertiary centers. And
Reference.
socially, of course,
Yeah.
yes, socially, of course, it's a country that has evolved over many years. If we compare that to the UAE, UAE is a public-private partner in the sense everybody has insurance and the insurance pays for whatever care we deliver. But
Yeah.
the insurance, it depends upon what class you come from that you have that type of insurance. So you have very good insurance, mid-level, and then poor insurance. So the treatment is basically determined by the type of insurance you carry because the additional payment has to be done by the person getting care. So suppose if you have a low level insurance, number of procedures are not covered, number of scans are not covered, and people really struggle to pay out of their pocket because care is very expensive here.
Okay.
Culturally, it is different because UAE is more conservative. Um, of course, termination of pregnancy is not allowed,
So that's what,
the
yeah, carry on, carry on. I'll just come to my next question. Hello?
Yeah, so I think that's the major difference. Basically, I think UAE is a smaller country, very small population, maybe around 9 million, which is less than the size of Mumbai. I think it's one fourth,
Mhm.
three fourth Mumbai. So it's much more different. So there are similarities, but there are huge differences between the three countries. Patients'
How does it work?
expectations.
How does it work? I mean, there is no private system at all in the UAE, or everything is insurance based, or if a patient wants to have requires an in utero surgery, and if the insurance doesn't cover for it, then I mean, what is the other option they have? Like most of the
So
patients in our country that they face, you know.
So everything is private in the UAE.
But that is very
You
expensive, isn't it? Like any.
you can choose the hospital based on your insurance. So if you have a lower level insurance, there are hospitals that only cater for that particular card. Fetal therapy is very expensive. It's only covered for people who are very rich.
Hmm.
Unfortunately, diseases don't choose rich and poor. They happen in every category or social class. And that's heartbreaking because we cannot deliver care to people who need it most of the times. So yeah, that's a big problem.
So, as you were saying that the cultural differences about termination not being allowed in the UAE, and is that one of the reason why we are able to see more such in utero surgeries in the UAE? You think? Because here the minute we start talking about, I mean, it's such a um, I mean, as we're seeing the evolvement, the evolution that has come up with in utero surgeries, here when we talk about it, the first option is very easy of termination. They don't go beyond that. So, is that the reason why do you think? I mean, because we also want to learn and do such things in India, where we're calling you as an expert. But that sort of a barrier is there. The easy option of termination is sometimes very frustrating for us when we try to counsel patients. I know the
So I think
expert.
there
Yeah, go
are three
on.
main things. One is that the expertise is available.
Yeah, true.
Secondly, termination is illegal or not allowed. It's only allowed for trisomy 18 and some other lethal abnormalities that also you have to go through a big panel and get it approved from there. So termination is a problem.
At any
Third,
gestation, you have to go through the panel.
correct, correct.
Right.
Uh,
Okay.
Thirdly, the social system. So for an Emirati to have a baby that may need support, the society supports it very well. They get paid, they get looked after. So having a limitation or special ability is not a limitation. It's okay to have a baby with that would need support for the rest of their life.
Right.
And fourthly, it is that majority of the locals have been exposed to the West, and I think they are a bit more pro-life,
Mm.
and they believe in giving the best to their children, irrespective of whether they would have any physical or mental challenges in the future. So I think those are the four things that make it different.
That support system is also there even after the baby's born, isn't it? Which is very
Absolutely.
important.
Throughout
Yeah,
their life.
throughout their life, right? So,
Uh,
in
People
so
of determination, they are called as.
right, okay, okay, okay. So, how do you see the two countries, or even from the UK, we can sort of, learn from each other to improve. We have certain deficiencies, but we have our potential as well. So, how do you, having worked in all these countries, look at as a positive way of learning from each other, how we can put the best in fetal medicine practice, you think? Your thoughts on
I
that?
think it's I think it's a two-pronged or three-pronged approach. I think one is knowing that fetal therapies are possible. I am not in any way saying that all of them are successful,
True.
but there are chances of making life as normal as possible. Of course, there is no guarantee of anything anywhere, but these therapies are do make a big difference. Secondly, is if we are convinced that these are useful therapies, then we will be able to offer that to our patients, and patients will, of course, get the confidence from their caregivers. Thirdly, I think it's about the cost. And I think as more people do it, as more people get trained in doing it, as with any other thing, the costs are going to come down. So I
Yeah.
think those things are the main drivers of change for the future. Maybe many years ago, we also thought that uh, lasers is not useful. We should probably let babies pass away. But today, none of us thinks like that.
Yeah.
I'm sure in the next maybe 5 years, 7 years, 10 years, we think about the same about other fetal surgeries. It's a journey that we all have to go through.
True, and it's an ever-evolving journey with load of expertise and skills coming across, and with with the evidence coming for it. Obviously, we need more. So, tell us about the sort of fetal surgeries you perform now. We know about the in utero, but in India, it is just coming up. We do very successful IUTs, lasers. Of course, you know all that. But from where you have learned, what other surgeries for our audience that you have been doing and successfully doing?
I think there are two major ones that are that we do. The one is spina bifida, in utero spina bifida, and one is diaphragmatic hernia occlusion, tracheal occlusion that helps babies with severe and moderate congenital diaphragmatic hernias. Having said that, Sita, I think most of the fetal medicine is what we do is high risk obstetrics. So for me, my routine work is dealing with severe preeclampsias, preterm labors, previous stillbirths, previous congenital malformations, or babies with current severe congenital malformations, genetic defects, chromosome. That's our basic bread and butter. On
Absolutely.
top of it, yes, we do get spina bifidas, and we may counsel parents towards whatever they want to choose. Ultimately, the basic remains that we will support the parents in whatever they choose. I am not the one who would say, please don't terminate and go for spina bifida. Ultimately, it's the parent's choice. We are there to give them unbiased information, and then if they choose to have a spina bifida repair, then of course
Yeah.
we will do that.
I don't think we should play God, or try and influence their decisions. As you rightly said,
No.
just give them informed, correct information and direct, and then they can decide on what they want to do. Because every couple, it's different perspective for them, in terms of their
Yes.
background, their social structure, and their ability to support these children. So it's very important. Yeah. So, can you just, share some memorable cases that you have had, in the UAE, or, wherever you have practiced, so that you can share your success stories, for interesting cases of fetal medicine or fetal surgery, whatever you would like to share your experience.
I think every case is a challenge. Every parent who comes to us comes with a hope. This is not only for patients who have had babies with abnormalities, but also for parents who have had a previous poor outcome. One of our roles is to do bereavement counseling, and these parents that have lost babies, especially who may have lost more than one babies, for them the journey is very difficult. And just holding their hand in pregnancy and making sure that they go through the pregnancy safely. Sometimes you feel that you're not contributing a lot, but actually you're contributing a lot emotionally to them, and taking them safely through the journey. And that, I think, is a big contributor. Um, and since we have been talking about fetal medicine and fetal surgery, I can share a recent case that we went through a lot of ups and downs. And that was a baby who presented to us at around 20 weeks. This is a local couple who were in their first pregnancy. They came from Dubai. In Dubai, they told them that the baby has hydrops. So they came here. When we scanned them, the baby had a left-sided congenital pulmonary airway malformation, a huge cystic lesion that was compressing on the heart and causing the baby to go into failure. The baby had pleural effusion, ascites, skin edema, and was really in a very poor condition. So we thought, okay, we didn't know the karyotype of this baby. We thought it may be a chromosomal abnormality, but there was an obvious big CPAM that was diagnosable. So we took her to theater and we said, okay, let's do a shunt. But in the middle is the part of the insurance. The insurance says, well, we are not going to cover for this procedure because it's expensive. Now, to tell parents that your baby is going to die if we don't do the procedure, but to do
Not
the
going to
procedure,
help.
you have to go and pay a huge amount of money was very difficult.
Yeah.
The parents went and paid the money. They were very upset that at this stage where they didn't know whether the baby was going to live or not, and we were talking about money. They paid. We took her to theater with hope that be able to put a shunt. So when we put a needle in, and when we went close to the baby, we could not introduce the shunt into the chest. But what we did was we put the needle into the lesion, took all the fluid out. The reason why we could not put the shunt in was because the baby was very close to the uterine wall.
Oh, okay.
And
Okay.
for you to release the shunt, you have to have some space
Great.
between the
Yeah.
uterine wall. Otherwise, the shunt comes out of the uterine wall, and then
There
it
was
becomes another.
it was not polyhydramnionic by the hydrops. There was
No, she didn't have polyhydramnios.
very interesting. Okay.
So we came out and then we told the parents that, sorry, we couldn't put the shunt in, but we have drained the cyst, and
Yes.
hopefully that should do the trick. They went home, came back next week, and the baby was perfect. No hydrops, no pleural effusion, no pericardial effusion. Ascites had resolved.
Oh,
The lesion was small. So it was a very good thing because this was confirmatory that the hydrops was because of the CPAM.
okay.
So we said, okay, fine, come back in 2 weeks' time. So then they come back in 2 weeks' time, and the baby was exactly the same as it was when they came for the first time.
That's
Hydropic, ascites, pleural effusion, skin edema. And at that stage, we knew that there was no other option. We have to put in a shunt, otherwise this baby will die. And she was only 24 weeks at that time. So we took her back to theater. Again, went through the same struggle of insurance, money, all that emotional trauma of asking people to pay money when they cannot probably afford. Um, that evening, we were able to put shunts in the baby. We put two shunts. We put two shunts just in case if one got blocked, because from 24 to 36 weeks
long
was a
time.
long journey.
Yeah.
Yeah. And we were able to successfully place two shunts in that baby's chest. And from then the baby did very well. The baby's CPAM collapsed and hydrops resolved. Baby was growing well, and then we delivered her at 36 plus weeks. And then the baby had surgery to remove that CPAM. And after 6 weeks, the baby went home with the parents.
Oh, that's wonderful, because we was obviously tend to say hydrops is a prognostic and feature, and once hydrops, then the chances. So it's not always what we think, as we say, and sometimes even if they don't do anything, very rarely, of course, that happens. We tend to say that yes, it's going to be very bad prognosis. There's a gut. Like recently, we saw a case that there was major significant dilatation of the large bowels in the fetus. And though the perianal complex looked all right, it looked like a slightly higher obstruction. and we did, say it could be bad. The fetus will possibly need some sort of intervention or surgery post delivery. But these sort of cases, sometimes they just, the parents didn't want to do anything, and the baby was fine postnatally. So it's sometimes, yeah, we tend to put up sort of prognosticated badly, but yeah, God has something else in store. And as you said, if you intervene the right step in the right way, I think that gives a lot of good hope for these women. So that's very interesting, and thank you for that. But if you sort of could combine the best of the fetal care in India, UK, and the UAE, what would, in your opinion, be the sort of role model fetal medicine care that we can offer? And also in respect to this, I wanted to know, how is the acceptance of doing genetic tests in the UAE with these women? I mean, because now genetics has evolved so much with fetal medicine, we cannot think beyond or proceed to do anything without having. What is the general acceptance of doing these genetic tests? And do you do a sort of whole exome, as they would recommend in the most of the Western countries nowadays for some of the anomalies?
I think acceptance is okay. However, the problem again is the cost.
Yeah.
As it is in India, it is the same here. For the local population, the UAE government pays for the whole exome sequence. They do it locally, but for anybody who is not a local, they have to pay. And just to give you an idea of how much they have to pay, they pay around 4,000 dirham for a whole exome sequence, which is around 80,000 rupees for an whole exome sequence. That's the cost of whole exome here. Having said that, I think it makes a big difference having whole exome
Oh,
sequence, because otherwise we would miss a lot of genetic defects. And I think it's a big game changer. Coming to the question of what would be the ideal care, I think it's not just fetal medicine. I think obstetrics in general needs to change. I think we think about pregnancy as more of a disease. And it is not a disease. It is anything like having a menarche, menopause, you have a pregnancy. And I think medicalize pregnancy. Pregnancy has to be a pleasant experience for the mom and the family. It is like a celebration for for a family. Unfortunately, not unfortunately, I think the way we have been trained, we maybe medicalize or over medicalize pregnancy, because essentially 80% of women are low risk, and that's determined by nature, and that's been the case for thousands and thousands of years. This nothing new.
best
And
example was COVID, which sort of showed us that, nature can do everything.
absolutely. And if we were to pick up the high risk women only, the women who do not adapt themselves well to pregnancy, and focus on that group. And of course, from the low risk group, there are women who will become high risk. Pick those up and leave the rest to deliver normally at wherever they wish to. I think that would be the ideal obstetric care system. But I think we are far away from that. That's not just for India, but even for the West. The West also is over medicalized obstetrics, except for a few countries in Scandinavian countries that are
Yeah.
really
Yeah.
made it risk. Ultrasound, I think ultrasound, there is no doubt, is an inherent part of obstetric care. The 12-week scan, the 20-week scan, and the 36-week scan have been proven to be mandatory and have a significant role in making sure that pregnancy is safe. Of course, additional scans are wherever indicated for high-risk pregnancies have to be done. And women who have unfortunately developed complications like severe preeclampsias or heart disease in pregnancy, or rheumatoid arthritis or some sort of immunological disorder in pregnancy, they need to be treated by doctors who are trained to deal with medical complications in pregnancy. I think that would be the ideal system.
Yeah. Multidisciplinary approach with all these patients, true. And I'm sure in especially in the UAE and other countries, the multiparous patients, in the increasing incidence of PAS. Do you see that often as well in your practice with obstetrics?
Um,
Placenta spectrum with or do they go in for more? There are more like here where cesarean section is increasing cesarean section rate is a major concern. So, do you see a lot of those complications as well, besides all these medical disorders?
I think it's interesting because I would see more pass in the UK, whereas in the UK, women would have one or two children. Whereas in the UAE, because it's a small country, the local population is encouraged to have more children. So
Yeah.
having 8, 10 children is not
Oh,
uncommon.
yeah.
Having 5, 6, 7 cesareans is not uncommon. However, a placenta accreta is lesser in the UAE than in the UK.
Interesting. Okay. Yeah. Because the minute we, more than two, three, that's the first thing we sort of start counseling them and we say to sort of dissuade them from having more pregnancies. But in UAE, that's, as you said, the norm is to have 5 or 6 children. And so that's one interesting difference that we have to see.
So
So,
there is more to pass than what we understand. I think there is a geographical variation. There is more to it than just being more than two cesarean being a risk factor. We screen all our women with two cesarean sections for placenta accreta, and we don't find that to be the case more often.
mm, mm. So, in your, what would you suggest in terms of fetal medicine training? In terms, and in India, there is a lot of potential. I mean, we have the best of fetal medicine experts in India as of now. But in sort of your advice, what would you be want to train in fetal medicine and fetal therapies? Or what would your suggestions be? Because you have been through the best. I think you've had been lucky enough to have the best of all three worlds. So for budding fetal, especially because nowadays, as you said, ultrasound is the key, but a lot of the young specialists want to jump into interventions before learning, so your advice in that aspect, because you've been through it from the beginning and from, in a stepwise manner.
I think fetal therapy is a very, very, very small part of fetal medicine. And I think it will not be possible for all of us to be doing fetal surgeries because simply there aren't enough cases or there aren't even enough procedures that are proven to be useful. Fetal medicine is one of the youngest branches in medicine and is evolving very rapidly. Um, I think the more people join fetal medicine, which is an extension of high risk obstetrics, the more safer pregnancy care would be, and ultimately that will help us reduce maternal and fetal morbidity and mortality. So I think it's an extension of uh, high risk obstetrics. More people join, the better it is. With regards to um, advice regarding joining fetal medicine, I think what we need to do in India, India has done extremely well in the last 10 years with regards to fetal medicine. There are so many people who can do good scans and pick up abnormalities. However, if I was to ask what would be the next step, I think the next step has to be standardization of our training programs. It has to be recognition of the training programs and a good blueprint of these training programs to a Western training program so that our training, our degrees are recognized and give us the best so that when we are out, when we have finished the training, we are able to deal with majority of the malformations with a good team around with good success. I think that is essential. You often see people having 3 months diploma, 6 months diploma, 12 months diploma, and I'm sure they do equally well. However, unless we standardize our training, we will not be taken seriously, even though we may be doing good work. I think that's where I think Sita, you would second as well, that we have always lagged behind in standardization. When we go to the West, our credentials are always challenged, and we have to do exams and proving ourselves again and again. And I think we should take an opportunity of trying to avoid that anymore.
Yeah. And I mean, we have been lucky enough to have the best of the teachers in India. We have so many, starting from Dr. Professor Suresh and so many of them, Dr. Khurana, everybody. so many of them are there to guide us, to teach us in the right direction. I think if we, as you said, if we structurize the whole thing and standardize the whole thing, it's obviously going to benefit us, which is coming up, but I think it will take its time. Even for that matter, even doing tests, because we don't have a structured system of screening. I mean, it's sad to say that even now we are doing the triple test where, where all of the time we speak that it is no longer valid, no longer sensitive, but we're still doing that. There's so much of disparity, variation in the way we practice. So all that needs to be standardized, and that is, I think, where because people are recognizing our work in that respect, the skill and the research that's going on, because we have the volumes, we have the numbers, and we have the skill as well. Not to say that, but yeah, that is something we need to know. So, is there anything that the West can learn from us? So we always have to learn from the West.
Absolutely. And I think the West has a lot to learn from us. West has to learn obstetrics from us.
Absolutely.
In fact, even in the UK, even now we tell our trainees that if you really want to be good, you need to go back to India. And we're happy to arrange training in India because that's where good obstetrics happens. And I think that's we are where we are only because we had our training in India. I wouldn't be here if I had not done my training in India, and I have absolutely no hesitance in saying that.
No, I think they also realized that. I remember as when we were, registrars, they was to be happy that we were as registrars, because the obstetrics were sort of more or less looked after, or they wouldn't have to worry so much, especially so that was something we were very proud of because of our training back here, and, the type of cases that we had dealt with. And yeah, so now how does the training system work there in the UAE, in the sense, like how do do I mean, if somebody wanted to come and do some learn or practice fetal medicine there, how would it be amenable? Like how people go to the UK, would it be conducive for Indians to come and do their training or work there, like you have done?
I think the system is evolving. It's a very young country. Remember, it's got independence only in 1972, and the real progress has happened only in the last 10 years. So there are 8 medical schools now, and the trainees are coming through. However, the training system is not yet very strong. They are trying to put in new programs, and because majority of the setups are private, they don't really have a good strong training program. But having said that, things are changing. Um, it will take a bit of time for fetal medicine to mature in the UAE. So I think even
I think you're
today,
there to make it excel now. So you're one of.
yeah, I think even today, UK still remains the better training system, because when you're in training, you need to be able to get exposure to different complexity of cases. And I think that's possible in the UK rather than the UAE. And that is the reason why we have not opened a fellowship program as yet.
Right. Okay. But it's been a great help that you have come down to India. Whenever we call, you're there to help us, to guide us, and to train our people here. So that's a big thank you from all of us, and I hope you continue to do that. But your sort of advice to the budding fetal medicine specialists, because it is, as you said, a lot of them are now not taking obstetrics as a choice, and they want to go into fetal medicine because to some extent it is more or less, it is very attractive. And, so your advice to the young ones, young guns there who are budding to aspire, be like you.
I think there are two parts. One is that we cannot do good fetal medicine without good obstetrics. So we have to be able to do both. Having said that, I know the complexities in India that people have to, by choice, leave obstetrics. But having a buddy as an obstetrician is always the best thing to do, even if you cannot do obstetrics on your own, because ultimately fetal medicine is just doing good high risk obstetrics. Secondly, I think for the young people who are coming up or getting out of training, I think perseverance is the most important thing. You have to keep on banging the door. This is something that somebody told me long time ago, that keep on banging the door, one day it will open. There is no barrier to what we can achieve or do. When I went to the UK, the numbers were very difficult to get. It was almost impossible to become a consultant in the NHS or to do a subspecialty training in the NHS. However, things changed and things keep on changing. So don't be put off because of what you hear in the news or what people tell you. As long as you are committed and know
Created.
and determined, I think there'll be people like Bhaskar who will always be there to push you and ask you, ask you to go ahead and do things that challenge yourself, basically. And I think the future is bright with AI coming into fetal medicine. I think fetal medicine will change a lot for the good. And I think we will see much more healthier babies and mothers than we are seeing today.
Yeah, true. How much of AI is being incorporated in your practice now? Since we've talked about AI, I'm just interested to know in.
Machines are incorporating AI. So at the moment, they are more about labeling, they're more about automatic measurements,
Are you
and
using that in your practice too?
they're in the machine. So it's easy. We
Yeah.
just have to tweak it a bit around. It then becomes habit. But those days are not far when AI will be significant in fetal medicine.
And how do you see the future of fetal medicine found and fetal therapy in the next sort of 5, 10 years? Your vision or your thoughts on that?
I think we are now getting good at operating babies at 24 weeks. And I think that's a very good thing
Yes.
because if you can treat malformations, abnormalities at 24 weeks, then really those abnormalities don't remain for the future. But having said that, there is still a long way for us to go with regards to fetal therapy. I think we need to be able to propagate, we need to be able to teach more people to do lasers, simple things like lasers, transfusions, shunts that are more common. And fetal therapies will keep on progressing. So I see a very bright future for fetal medicine and therapy in the next 20 years.
Wonderful. That's very encouraging coming from you. But any parting thoughts on, we've had different aspects. So just as we are ending towards the end of our podcast, anything that you would like to tell or share before we bring it to a close?
No, I think the next century belongs to India.
Oh,
We have a huge, young, energetic uh, doctor population, and their determination is huge. So all I would say is don't feel undermined or don't feel dejected by the challenges that come through. Challenges have always been there. If you want to do something, nothing can stop you from doing it. And you can see me. I have come from a I've come through all the challenges, not because I was great in any way, but because the only thing that made the difference was perseverance.
yeah.
If I had gone into GP when I went to the UK, I would not be an obstetrician anymore or do fetal medicine. So don't
Challenges make you grow. It sort of, inspires you, and it's the way you take up the challenge, isn't it? So that's very important. Yes.
don't hesitate from taking up any challenge because that's worth it. It's worth it. And medicine in itself is a beautiful profession. So we all need to continue. I know there are challenges. There are challenges about litigation. There are challenges about patient understanding. But challenges will always be there and we will continue to evolve.
Thank you. Thank you. I think it's been a very interesting conversation, Dr. Mandeep. And so thank you for sharing such rich insights about how we practice here, yet, deeply connected worlds of fetal medicine we have. I think it's very clear that we have our unique challenges and approaches. But as you said, there is incredible potential for collaboration, innovation, and sort of shared learning that we can do. So thank you once again for being part of our podcast. And it's a pleasure having you. And hope to see you soon again in India with all your expertise and guidance and teaching as always. Thank you so much. Thank you.
Thank you. Thank you. My pleasure.
Thank
Thank you.
you. And this will be a recorded event, so I will share the new recording with you once it's out. So thank you once again.
Thank you.
Thank you.